Okay, thank you very much, Oscar. And I'd like to thank the organizers of this meeting, and I feel very honored to be part of it. And this afternoon, we're going to be talking about cardiac unknowns, different cases that we've had. Let me just adjust this a bit. Okay, can you hear me? There. I have no conflicts of interest. As far as the learning objectives, I think what's really important when we're screening for congenital heart disease and defects is to have a very standardized approach. So hopefully I will impart that to you as we go through the talk this afternoon. Understand how some cardiac defects can evolve over the gestation and what we can do about some of them, and talk about some more common and then a little bit of esoteric diagnoses, just to kind of prompt us to have a very full evaluation of the heart whenever we scan patients, especially in the second and third trimesters. So our first case, 39-year-old gravida 3 para 2, who had an amniocentesis for advanced maternal age, and the fetus has Down syndrome. So she came in for a third trimester ultrasound to look at fetal well-being after having had decreased fetal activity. So this is a clip through the heart, and I think the defect is quite obvious here. We have the heart beating here. This is anterior, here's the fetal spine. So this is the right ventricle, this is the left ventricle, the right and left atria. So when we look through the heart, and I don't want to spend too much time on it, but I do think it's important, as I mentioned, to have a very standardized approach. So we want to look at the number of chambers, the situs, the rhythm of the heart, which looks okay, the position, okay, the size, it should be about 1/3 of the size of the chest. It looks a little bit bigger than that. You see the right side of the heart really goes almost over to the right chest wall. So that's a little abnormal here. The axis, if you divide the chest in half and look down the interventricular septum, the angle should be about 45 degrees. That it seems to be here, so that's okay. And now we want to look more specifically at the atria and ventricles. You can see both atria here, similar size as are the ventricles, except we see a defect in the middle of the heart, and that there's one AV valve. So this is an atrioventricular canal defect, very common in Down syndrome, but I just want to reinforce that we have to be very standardized, because there are some defects, as we'll go over, that do not have all of these abnormalities in them, and we have to be prepared to diagnose many different types of heart defects, and there may only be 1 or 2 abnormalities of the 4-chamber view. So when we look at the 4-chamber view of the heart, it's much more of an evaluation than simply counting to 4 chambers. We want to, as I mentioned, look at the situs, the chamber number, the rhythm, position, size, axis, and then more specifically at the atria, ventricles, the AV valves, and then the endocardium, myocardium, and the pericardium. Looking at the 4-chamber view is not enough, and we can really heighten our detection rate by extending the evaluation. So if we look at the left and right ventricular outflow tracts and the 3-vessel view, that's going to be very helpful. I'll show examples as we go on. The aortic arch is something that is a little bit more challenging to look at, especially in the 3rd trimester, and the superior and inferior vena cava are also something that can be helpful for us. So let's look at another example. Here we have a heart, here's spine, so this is anterior. We see the chambers, and we see that the heart is a little bit large for the size of this chest. The axis is a little, I would call it level rotated. If you put a line down the interventricular septum, it's a little higher than that 45-degree angle. There seems to be a difference in the sizes of the atria and the ventricles, with the left side a little bit smaller than the right. The right is usually a little bit larger, but there's not such a dramatic difference. And this is a fetus with coarctation of the aorta. So that's something that we can be suggested based on these findings. Here we have a still image, but we can see this is a very abnormal heart. The heart is very enlarged. You see the right atrium going way over onto the right chest side wall. The axis, it's almost lying flat in the chest, and the right atrium, is much larger than the left. And we see that the AV valve is much displaced into the right ventricle. That's a fetus with Epstein anomaly, and that's pretty obvious, but I want to reinforce that it's important to have that standardized approach as we're looking at the heart. Here we have another case, 4-chamber view of the heart. We see that the size is much larger again, and the axis is, again, very flattened in the chest, so it's over that typical 45-degree angle we talked about. And we see this defect, which is a VSD, a ventricular septal defect, between both chambers of the heart. Here, we're looking at a heart. This is the chest, and here's spine, so this is anterior. So we see really no right ventricle or right atrium. We see the left ventricle right here. So clearly there's an abnormality with the number of chambers in the heart in this one. And the right atrium and the right ventricle are clearly non-existent. Here we have a little clip of that where you can see the left ventricle contracting nicely, maybe a little bit of lumen in that right ventricle, but no blood flowing through. And that's a fetus with tricuspid atresia. Let's look at another example that's a little more subtle. You can look at this 4-chamber view and think that it may not be too bad, except the position, it's a little pushed over to the right side of the heart. And again, the axis of the heart, which is a really good sign for structural defects of the heart, especially conotruncal abnormalities, something that we have to be very aware of. So if you just looked at the ventricles and the atria, they look fairly symmetric and they seem to be fairly normal in appearance. If we look at clips though, we see that there is a difference in, a slight difference in the sizes. We see a ventricular septal defect here, and we see this overriding aorta, which comes out of both ventricles. So this is a fetus with tetralogy of Fallot. And it may not have been exactly apparent if we had just looked at the 4-chamber view. Now I have a few cases that a little less common, but I wanted to include them. We've trying to mix it up as we look at different abnormalities of the fetal heart. This was a 35-year-old G2P0 who had a normal 18-week survey except for an echogenic intracardiac focus. Then she came in at 32 weeks for size greater than dates. And what we see is a lot of fluid. So there's moderate polyhydramnios and a very large fetus. But when we look at the heart, we see, what do we see here? We see, here's a great vessel, but we see a lot of really increased echogenicity of the walls of the pulmonary artery here. We can look at Doppler of the AV valves, and you see this nice bifid character of the waveform, which is very normal for those. Again, we have increased echogenicity here of the pulmonary artery, of the aorta on cross-section. And if you look at the waveforms of the left and right ventricular outflow tracts, you see normal flow. When we extend our evaluation down into the abdomen and pelvis, you can see increased echogenicity of the aorta, iliacs. So I have two more cases that are similar. I hope this is generating some thought because it's a very unusual finding. This next case set of monochorionic diamniotic twins, and one of the twins had a pleural effusion and also had polyhydramnios. Here we see quite a bit of fluid in this sac for the presenting twin, twin A. There is fluid in the chest. You can see this nice four-chamber view, but we see a lot of excess fluid there. When we look at the left ventricular outflow tract, it looks like a normal lumen here, but the walls of the aorta are very, very bright. And one last case, 32-year-old with a family history of congenital heart disease and sent in for a structural fetal survey. Here we have the right and left ventricular outflow tracts. Here we have, in the right ventricular outflow tract, you can see that the walls are quite bright, as is the left. When we extend the evaluation into the abdomen, you can see the aorta similarly is quite echogenic and bright, and you can see the iliacs the same. Anybody have any idea what this is? It's a very rare entity called idiopathic infantile arterial calcification, although they recently are trying to change the name to generalized arterial calcification of infancy. It doesn't really apply because we see it in fetuses, but it is a very rare cause, and we've had 3 cases over the past probably 5 years of this. The last 2 cases I presented both died, unfortunately. The first case was in the hospital for 11 months getting therapy aimed at reversing the calcification. So it's a very difficult disease with no current cure. Let's look at some other examples of other congenital heart defects. Again, we want to go back to our systematic approach where we're looking at the 4-chamber view. And what do we see here? We see a 4-chamber view in the heart, the position a little bit large, abnormal axis of the heart. And we see that the right side, because the spine is here, so the right ventricle is the more anterior ventricle. Here we see the right ventricle, the left ventricle, the right and left atria. And you can see that the left side of the heart is quite small. This is a hypoplastic left heart. And here is another one, just to cut to the chase and tell you what we're faced with, but sometimes it can be a little bit more subtle. What do we see? We have a 4-chamber view here, and this is a developing aortic stenosis that's developing into a hypoplastic left heart, but there's not as many features because it's earlier in the process, so we don't have the same number of features to help us make this diagnosis. The size of the heart is fairly large. We see the atria are fairly similar in size, except we see the flap of the foramen ovale bulging into the right atrium instead of the left. So that should tip us off that we're facing something that's not quite normal. What else do we see? We see fairly equal sizes of the ventricles, but as I mentioned before, the right ventricle, which is the more anterior one, should be a little bit larger than the left. And we see the left ventricle a little bit larger, and we also see a little bit of echogenicity here of the interventricular septum. So even though we can count to 4 and look at the 4 chambers of the heart, if we're really critical about our evaluation of the heart, we can see that there are a number of abnormalities here that should tip us off that there could be a problem. So this is the same case, and we're going to look at the heart in motion. And as you can see, when the heart is beating, there is a very pronounced difference in both the left and the right ventricles. The left ventricle is very poorly contractile, and you see much larger right ventricle. If you use color Doppler, that can help you. I don't think that changes what we see with the grayscale, although you see very little flow going into the left ventricle. So what can we do about this? At Brigham and Women's Hospital and Children's Hospital in Boston, we've really tried to either prevent, reverse, or minimize the degree of left ventricular failure that goes into hypoplastic left heart syndrome. So if we catch some of these critical aortic stenosis cases early, there might be something that we can do. This could be a whole nother lecture, but I just want to highlight some of the things that we've done. So as I mentioned, if you have critical aortic stenosis, there's an obstruction of blood flow through the left ventricle. So initially what you're going to see is that the left ventricle will balloon out and be somewhat large. After there's some damage to the left ventricular myometrium, the endometrium and the myometrium will become somewhat echogenic, and we saw examples of that. And then you're going to get more poor left ventricular contractility and growth, which we observed in those other prior cases. And then the left ventricle will progressively get smaller until it becomes almost difficult to see. So when we look at the left ventricle, we can see that poor contractility here as the heart is beating. So here's a view of the heart with this smallish left ventricle. So what do? We put a needle through the heart that goes up to the valve, and we have a guide wire, and then a balloon will be placed right over where the valve is, and it'll be inflated so that we can try to open that valve somewhat, so you'll get more of the flow, so that will hopefully, and our goal is to preserve left ventricular function. After the procedure, you can see increased flow, as shown in this clip. There are other cardiac surgeries that can be done. I just want to concentrate on aortic valve dilatation procedures, because that's really something that we think is the primary indication for cardiac surgery. And it's certainly a learning curve, although we've had the vast majority be successful, and we do think that that does help protect that left ventricular function. So looking at a few examples, both pre-op and post-op, you can see poorly contractile left ventricle that really has improved contractility post-op. Another example with color, very little flow out the left ventricle preoperatively. And there you see much better flow coming out of the left ventricle postoperatively. Okay, let's look at a few other cases, different types of diagnoses of the fetal heart. A 31-year-old with a second opinion for congenital heart defect. So what do we see here? We see a difference in size of the ventricles. And we see this arch, although it seems to be somewhat narrow, right at the top of the arch here, and then it kind of balloons out a little bit. You could use color. I don't think that really changes how we see difference in sizes of the ventricles. And then the three-vessel view, which I mentioned at the beginning of the lecture, can be really helpful. So what do we have? Going from left to right, kind of at an angle most typically, we'll see the pulmonary artery, the aorta, and the superior vena cava. And the pulmonary artery is usually the same size or maybe slightly larger than the aorta. And both of those should be a lot larger than the superior vena cava. If we look at the clip here of the arch, you can see clearly it's thinned and abnormal at the very top of the arch. So in reviewing the findings in this case, we had the left ventricle smaller than the right, somewhat hypoplastic left ventricular outflow tract, and a hypoplastic aortic arch, and these were confirmed after she terminated the pregnancy. If you look at the three-vessel view, it's a very important view as you're evaluating the fetal heart. Again, here we have from left to right the the right ventricular outflow tract, the aorta, and the SVC, and we work our way a little bit higher in the chest, you'll see that the ductus arteriosus will kind of join up with the aortic arch until you see them kind of joining in this little heart-shaped view at the very top. You should see blood flow going in the same direction in both of those vessels, and you can see that shown here. Color isn't necessary for evaluating it, but it's important to really look at this three-vessel view because any type of conotruncal abnormality can be much better ascertained by incorporating this into our evaluation of the fetal heart. Here we have a 28-year-old primiparous patient, prior preterm delivery for a structural survey. And here we have, actually this picture is very important because we see one main artery leaving the heart, but we can see a little bit of a bifurcation here into a pulmonary artery coming out. So this is one large vessel leaving the heart, which is what we call a truncus arteriosus. Here we see an abnormal face here, and then that vessel coming out of the heart with a little bifurcation of the pulmonary artery. So in reviewing this case, there's a single outflow tract, an abnormal face with micrognathia. So this is a fetus with DeGeorge syndrome. Very important because they not only have cardiac abnormalities, but abnormal facies, thymic aplasia, cleft palate, which kind of goes along with the micrognathia, and then other endocrine disorders. Next case is a 32-year-old nulliparous patient, here for a second opinion for congenital heart disease at 36.5 weeks. This is a very interesting case because it was difficult to really figure out what was going on here. The structure of the heart looked normal. We see the four-chamber view, a little bit large if we want to go through our criteria as we systematically evaluate it. The right ventricle and right atria being a bit larger than the left. I think we can see that here. Spine is down here and anterior is up here. So if we look at our three-vessel view, again, a very important view. You see a little bit of the right ventricular outflow tract, and we have this kind of diagonal from left to right of the right ventricular outflow tract, aorta, and SVC. You can see as you move up in the chest a little bit higher, you see the aorta and the SVC, but the pulmonary artery, the ductus arteriosus, becomes very thin and wispy here, almost non-existent. If we put Doppler on, we can see in the right ventricle, instead of that bifid character that we saw earlier, we see these very strong peaks of flow into the right ventricle. And if we put our gate right into the right atrium, we see a huge amount of tricuspid regurgitation. I think I have a clip here that's going to help us. So this is kind of going through our three-vessel view and a little bit higher in the chest. You can see that there's a little bit of a wispy, the ductus arteriosus starts out fairly good size, but then it becomes very constricted as you get higher in the chest. So we have a enlarged right atrium, right ventricle is larger than the left. We have that the three-vessel view lower in the chest, it appears fairly normal in appearance, but as we move up, it becomes a very small ductus arteriosus, part of the right ventricular outflow tract. We have very significant tricuspid regurgitation and a hypoplastic and very tortuous ductus arteriosus. We'll come to find out the patient was taking ibuprofen, Motrin, which is something you don't want to take in pregnancy, and had premature constriction of the ductus arteriosus. Here, I think this might be my last case, a 22-year-old G1, history of hydrops with cystic hygroma and pleural effusions, identified at the time of the nuchal translucency testing. Here for a structural survey, you can see this is the nuchal translucency with great thickening of the posterior nuchal area. You see pleural effusion here, maybe a nuchal cyst. If you look at the skin fold thickness on the back of the neck, 21 millimeters, should be under 5 or 6 millimeters, so clearly very abnormal. Again, in this transverse view of the chest, we see the pleural effusions. You can see the heart, the size of the two ventricles seem fairly consistent, although there is a little bit of a defect here at the level of the atria. If we want to look with color, there does seem to be a defect. This is at the level of the ventricles. Can't really see that so much without color. So we have a cystic hygroma, pleural effusions, atrial septal defect, a ventricular septal defect, probably some type of abnormality of the an atrioventricular canal defect, probably a partial one, given the ASD and the VSD. So the findings, she actually also terminated the pregnancy, and the autopsy findings showed low set ears also, hypertelorism, mild micronathia, and this was a fetus with Noonan syndrome, something that is a very serious abnormality. So that was my last case. I hope that you were able to take away developing a systematic approach when we look at the fetal heart, looking at not just the 4-chamber view, but there's a lot more information we can glean from that, looking at the vessels coming out of the heart, and also the 3-vessel view, which is very important as we're evaluating it. So thank you very much.